Okay, so we'll begin our lecture on care of the patient with non-inflammatory intestinal disorders. Before we begin, I wanted to do a patho review of the different organs of the GI system. So first to begin, your primary organs that are involved when we talk about the gastrointestinal system, you have your primary GI organs. So that's the mouth, the esophagus, the stomach, small intestine, large intestine, the colon, the rectum, and the anus. And then you have your accessory GI organs, which are the liver, the gallbladder, and the pancreas. So first, to kind of go over anatomy just a little bit. First, the stomach. You have the stomach that lies in the right upper quadrant. The stomach is lined with parietal cells, and so the parietal cells secrete hydrochloric acid, an intrinsic factor. And so the stomach acts as a food reservoir. It breaks down food by mixing it with the gastric secretion before moving the bolus, the chyme bolus, down to the duodenum. And then we have the small intestine. The small intestine is the major organ of absorption. The small intestine is long and thin. It's about 16 to 19 feet long. There are three regions of the small intestine: the duodenum, the jejunum, and the ileum. The small intestine mixes that chyme bolus that it receives from the stomach with many digestive enzymes. The ileum contains the ileocecal valve, which separates the entrance of the ileum from the cecum of the large intestine. Then after the small intestine, we have the large intestine. The large intestine is 5 to 6 feet long. So although it's shorter, the lumen of the large intestine is what makes it large. The function of the large intestine is it's for movement, absorption, and elimination. There are 4 divisions of the large intestine. It's divided into the ascending, the transverse, the descending, and the sigmoid colon. The sigmoid colon empties into the rectum, and then you have the cecum that lies inferior to the ileocecal valve, or right outside of the small intestine at the base of the cecum. Also, what you'll note at the base of the cecum, which is here, you have the appendix. And so right now, when we read about the appendix has no digestive function. It's just kind of hanging out there, not doing much, but when it becomes infected, it can be a really big problem for the person that develops appendicitis. But we'll talk more about that. The pancreas lies behind the stomach, and the pancreas has 2 major functions. It has an exocrine function, and so part of its function is to secrete enzymes for digestion of carbohydrates, fats, and proteins. And so those enzymes that it secretes are amylase, lipase, and trypsin. And then the pancreas also has endocrine functions that we learned about in 105. And so the endocrine pancreas contains alpha cells that produce glucagon and beta cells that produce insulin. The liver lies in the right upper quadrant. It contains right and left hepatic ducts. It performs more than 400 functions, and we will not go over all of those. But the liver is responsible for filtering about 1,500 milliliters of blood every minute. It's responsible for transporting bile. Bile is what's needed for the breakdown of fats. The liver is responsible for storing minerals, vitamins, iron, magnesium, vitamins A, D, and K, which are fat-soluble vitamins. The liver is needed to detoxify drugs, chemicals, and alcohol. It's also the main site of all proteins involved in coagulation. So if we have problems with the liver, well, then we have a lot of problems. The person is really sick when they have problems with the liver. And lastly, we'll talk about, mention the gallbladder. The gallbladder is responsible for storing bile. It lies underneath the liver. There's a common bile duct that joins the hepatic duct and the cystic duct of the gallbladder. But we'll talk more about all of these later. I like to do a review of the GI organs, so if you know what the functions of each organ are, well, when those organs are not functioning properly or we have alterations, if you know the normals, then you can kind of have an idea of what the abnormals are going to be. So first we'll begin with discussing this slide, lower GI bleeds. As you see here, there are a number of different reasons that patients can develop GI bleeds. Some are not as serious as others. Ulcerative colitis, polyps, they're not going to be as serious as colon cancer. Diverticulitis will not be as serious as colon cancer, rectal cancer, and hemorrhoids. So some of them, we have simple treatments that can be performed, or medication, simple bedside procedures, whereas with the others, such as your cancers, there is going to be more detailed treatments, such as maybe chemotherapy and radiation. But we'll talk more about these. First, we'll begin with discussing irritable bowel syndrome. So irritable bowel syndrome, as it says, it's a functional GI disorder characterized by chronic or recurrent diarrhea, constipation, and or abdominal pain or bloating. And so the Manning criteria, you have some of the Manning criteria listed for you up here. But usually these criteria include abdominal pain relieved by defecation or falling asleep, abdominal pain, a change associated with changes in stool frequency or consistency. The person is going to complain of abdominal distension, the sense of incomplete evacuation of stool, the presence of mucus with stool passage. And so usually a flare-up of a symptom usually brings the patient to the healthcare provider. And usually the patient typically complains of left lower quadrant pain when they have irritable bowel syndrome. And so when we're doing treatment for the person with irritable bowel syndrome, this disorder, it's a syndrome. Doctors seem to think that there's more of a psychological component to irritable bowel syndrome. They'll do different tests, different labs to see if there are any adhesions, any other type of structural problems, and usually they end up deciding that it's irritable bowel syndrome when they determine that there are no lab irregularities, no structural problems. Then it's diagnosed as irritable bowel. And so, as I said, it usually has a strong psychological component. People that have stress a lot will have irritable bowel syndrome. So with diagnostic testing, they find that there are no changes found with the gastric mucosa. As I said, the lab values are normal. There's no offending agent. The person does not have H. pylori, which you learned about last semester. So what we want to teach the person is to avoid problem stimulants. So avoid stress. The person may need to practice eliminating offending or upsetting foods. So caffeine, alcohol, eggs, wheat products can be offensive and cause things such as diarrhea. The person may need bulk forming laxatives, antidiarrheal agents, as you see up here, your 5-HT4 antagonists. And so when we talk about the person using a bulk forming agent, we use these because they're hydrophilic, which means they love water, and so this draws water in for softer form stools. And so we want to use this, of course, if the person is having problems with constipation. If the person is having diarrhea, then we can use anti-diarrheal agents such as your Imodium. The 5-HT4 antagonists, they block serotonin. And so we find that serotonin is found in the vagus nerve, and it's responsible for peristalsis. And so this that increased peristalsis that's causing the person to have diarrhea. So we're going to block that. And then the M3 receptors, these inhibit intestinal motility. And so this is also going to help with diarrhea. Again, stress management is going to be important in helping this person to alleviate the problems such with the irritable bowel syndrome. Complementary and alternative therapies may be used to reduce stress and the symptoms and discomfort of irritable bowel syndrome. I'll let you read over herniation in your book on your own. With colorectal cancer, most colorectal cancers, as it says here, are adenocarcinomas. They form in the mucosa of the colon. The etiology, usually you see this occurring in people that are older than 50 years old. It usually has a genetic predisposition. We see that it runs in families. The person may have a personal or family history of cancer, and then we'll discuss familial adenomatous polyposis. So 50% of U.S. citizens will develop a colorectal tumor or benign polyp by the age of 70, 50% of them. And so 10% of those will be cancerous. So when we talk about family history of cancer, people are at an increased risk if they have FAP or the familial adenomatous polyposis. And so that definitely is going to increase the risk of a person's risk of developing colon cancer. Dietary factors such as foods that are high in fat, a diet where the person is consuming a lot of red meat, fried and grilled meats and fish, they are connected with colorectal cancer development. Food diets that are low in fiber, and so these decrease the bowel transit time, and so what that means is it makes the stools harder and they reside in the colon longer, and so the hard stools are going to irritate the gastric mucosa, and so this increased contact with bacteria can interfere with the gastric mucosa and cause cells to become mutated. And so when we talk about adenocarcinomas, an adenocarcinoma is a cancer of the epithelium, and so they originate in the glandular tissue, and they usually have excretory properties. So it's those mucosa cells that are responsible for excreting mucosa. These are where these type of cancers are going to originate. And so when we talk about colorectal screening, as you see here, you see the different percentages, and so it's showing you where colon cancers usually develop. And so if you'll notice here, 30% of colorectal cancers will develop in the rectum. And so because of this, we have screenings that need to be done. Usually it's recommended that adults begin to have regular colonoscopies performed. If you have a positive family history for colorectal cancer, then your doctor may decide to begin colonoscopy screenings at an earlier age. But as we see here, 30% of colorectal cancers are found in the rectum, and so because of that, sigmoidoscopy should be performed every 5 years once a person begins having these screenings performed. So when we talk about health promotion and maintenance, genetic testing for the FAP gene and for HNPCC should be done. HNPCC stands for Hereditary Non-Polyposis Colorectal Cancer. And so it's an autosomal dominant disorder that sometimes people will have, and it increases that person's risk of colorectal cancer. And so we're doing this genetic testing. If the mutation is present, then the patient is at risk of developing polyps that can become cancerous. And so for this patient, there may be several surgical options that involve removal of the entire colon or both the colon and the rectum. A colonoscopy is considered to be the diagnostic test of choice, as it can provide not only a quantification of polyps or determining how many polyps the person has, but also doing a tissue sample or testing the tissues for biopsy. And so when we talk about diet modification, we want the person to decrease the amount of fats that they're taking in and increase fiber. The screening should begin at age 50 if the person has no family risk. If the person does have a family risk, well, then those screenings are going to be done at an earlier age. And once those screenings are started, then the person should have the colonoscopies repeated every 10 years. When we talk about supplementation of aspirin and calcium, both aspirin and calcium continue to be researched for their usefulness in preventing colorectal cancer. So that's something, as I said, that's still being researched. When we talk about clinical manifestations of cancer, the most common signs that a person may have are rectal bleeding, anemia, and an obvious change in the stool. And so the clinical manifestations of colorectal cancer depend on the location of the tumor. And so if you remember a couple of slides ago, I showed you different places within the colon that those cancers can develop. And so when we talk about a change in the stool, the person may go from having formed stools to having ribbon-like stools. And so usually the person will start to begin to have ribbon-like stools in the presence of a tumor. And so you think of a tumor that's developed within the colon, and so the person develops ribbon-like stools because now you have stool pressing past a tumor that's kind of it's a type of obstruction, and so as it presses past that tumor, then the person will have ribbon-like stools. Also, the person may start to have obstructions of stool passage because of these tumors developing. And usually we see these happen when the person has problems or tumors that develop in the transverse and the descending colon. The person may also complain of distension, and the distension is an abdominal distension, and it's usually an obvious distension that happens when the person has an obstruction. The person may have visible peristaltic waves that indicate that there is a bowel obstruction. So when we look at the laboratory test, it says that a hemoglobin and hematocrit may show to be decreased. And so this is because the person is losing blood through the GI tract. A fetal occult blood test can be formed. These with these patients may provide the lab with a stool sample for testing. And so this test is done to assess and determining if blood is present in the stool. It's not diagnostic in determining the location of the tumor, but it is diagnostic in letting the doctor know that there is blood in the stool and them determining where that blood is originating. And so after the fetal occult blood test is performed, the person may have a scope done, whether it be a sigmoidoscopy or a colonoscopy. And so when we talk about the different diagnostic procedures, a colonoscopy looks at the entire colon. And so we've already learned that we have the descending, the transverse, and the ascending colon. And so a colonoscopy is going to look at the entire colon, whereas with your sigmoidoscopy, it's only going to look at that one portion, that sigmoid portion of the colon. And again, that's because that's where 30% of the cancers originate. But if I had to make my decision, I would want the doctor to do a colonoscopy, just because we know that cancers can develop in other portions of the colon. And so when the colonoscopy is performed, imaging is going to show if there are areas of occlusions or any adhesions. Okay, an MRI can be performed, and so an MRI can be done to help determine if there are any areas of metastasis. The liver is the most common site of metastasis for colorectal cancer, and so cancerous cells of the colon or the rectum can spread also through the lymphatic system. And so some other places that can be affected are the lungs, the brain, and the bones. And so what we have to remember from our cancer lecture is that if a person has cells and they have maybe the person has polyps, and even if the polyps are not cancerous, we know that we have things that are promoters. And so once we have that those abnormal tissues that have developed, even though they're not cancerous, polyps can become cancerous. And so that's what we go in to remember those promoters again, those things like a high-fat diet, smoking, and drinking. Those things the person would want to cut those things out so that those mutated cells don't become promoted cells and become cancerous. Again, genetic testing would need to be done for the HPNCC gene, and also the person tested for familial polyposis as well. We're looking at non-surgical management. These are standards that are put out by the American Joint Committee on Cancer, and so this is just telling you how they stage cancer. Before any treatment can be done, we have to determine what stage the cancer is at first. And so when we talked about stage 1 cancers before, if it's caught early enough, the person may not need a surgery. The person may only need maybe chemotherapy. When we were talking about the breast, the person may only need a lumpectomy, which is a surgical procedure, but it's not removal of the entire breast. But depending on the area and the extensiveness of the cancer will determine how much surgery or how extensive the surgery is going to surgery is going to be. But first we start non-surgically to determine the stage and what treatments can be done for it. Also, non-surgical management can include radiation therapy, and so radiation is common and useful in rectal cancer. It's less common to help other portions of the colon, however. And so when anytime we're talking about radiation, make sure you review the principles of those persons that are receiving radiation therapy. And also in your book, it talks about the different types of chemotherapy that are used with colorectal cancer. So make sure you read over those things. And usually chemotherapy and radiation can be used together. So radiation is going to shrink the tumor, and then chemotherapy is used because it kills bad cells. We've already learned that, but it does that by destroying different segments of the growth cycle of those cells. Okay, so with surgical management, the person can have a number of different things done: a colon resection, a colectomy, an abdominal perineal resection, a colostomy, and there's also minimally invasive surgeries that are possible. And so surgical management, again, is going to depend on the extent of the cancer. A colon resection is removal of the tumor and regional lymph nodes. So with widespread or diffuse cancer, a colectomy may be performed, and a colectomy is when the entire colon is removed. And so of course we know if we're removing the colon, the person is still going to eat, so they have to have a means of eliminating waste products. And so we'll talk more about that because this person will need a colostomy. And so when we talk about the colostomy is an opening of the colon through the surface of the stomach. And so usually it can be indicated when anastomosis is when we're taking something out and we're suturing two ends together. So a colostomy may be done until anastomosis can be performed. When surgeries are done, it makes the bowel mucosa really inflamed, and at that point the doctors may delay anastomosing or attaching those two ends, and so a colostomy will be performed until healing takes place, and then the colostomies in some cases can be reversed. AP or abdominal perineal resection, this is performed when the anus, the rectum, and the sigmoid colon are removed. And so with minimally invasive surgeries, these are laparoscopic procedures, and they may be performed to remove tumors or to do colon resections, removing portions of the colon but not the entire colon. So with the surgical management of the person that's having surgery for colon cancer, before the surgery is done, we would want the person or the patient to talk to the enterostomal therapist, and this is the person that's going to come in and teach them about the colostomy. it's definitely important to make sure that they discuss these things before and that they know what to expect after the surgery. Definitely the surgeon is going to discuss maybe risk for sexual and urinary diversions. A bowel prep is going to be performed before the procedure. So with the bowel prep, this is maybe like a Go Lightly prep that you'll read about in your book. And so this is to cleanse and irritate that mucosa and get everything out of the colon before the surgery is performed. We will also want to let the person know that a nasogastric tube and an IV tube is going to be placed after surgery. And so again, we're letting them know these things so that they're not frightened after the procedure. Nasogastric tubes are going to be done because the patient after surgery can build up a lot of gas, and that abdominal distension is very uncomfortable for the patient. And so the nasogastric tube is going to be there as a means of providing decompression, and also any buildup of gastric acids. The nasogastric tube is going to help to eliminate those. And so the person may be assigned to a case manager also for long-term consequences. Sorry, y'all. And so these are the different type of colostomies that can be performed. So remember, when we looked at the different type of cancers, we know that cancers can originate anywhere along the large intestine. And so because of that, this is showing you the different type of colostomies that can be performed as a result of where that cancer originated. And so in your book, it will go over the different type of colostomies and when they're indicated. Down here with the sigmoid colostomy, usually when people have these tend to be more permanent. The sigmoid colostomy, you may see a person having these when they have cancers that are developed of the rectum, and so this person may have the rectum and the anus removed, and so now they have the sigmoid colostomy. And as I said, these type tend to be more permanent, whereas when you have the transverse, the double barrel colostomy, these they can be permanent, but they tend to be temporary until the person has healing of the gastric mucosa for surgery, for those two ends to be anastomosed or sutured together. So with colostomy care, what we need to know is the normal appearance of a stoma. And so we need to know this so that we know how to teach our patients. And so normally in the early postoperative period is going to be a reddish pink color. And so we always want to know, we want to monitor and tell the patient to monitor for changes in the color. If it's becoming ischemic, maybe it's becoming pale in color, definitely if it's becoming black. If the person is having unusual bleeding, these are definitely things that we want to make sure that they follow up with the doctor. Measurement is going to be important. We need to teach the patient how to measure the stoma, because we're going to have to be able to teach them how to fit their stoma devices. So we have different stoma devices that we can use to measure the stoma site and to fit the bags appropriately. And so we want to make sure that we're measuring correctly so that the person does not have leakage of stool outside of the stoma, because again, this is gastric elimination, so you have gastric acid and its waste products, so it's going to irritate that skin. So we want to make sure that the devices are measured correctly and that they fit appropriately. We want to tell the patient that they always want to empty the bag when it's half full, and this is going to just help with curtailing odor, help to cut down on odor. They may want to avoid foods that cause a lot of gas, things like broccoli, some of your green vegetables that cause a lot of gas. That gas is going to build up in that colostomy, and so we want to tell them to try to avoid those foods, but the person should be able to resume most of their normal activities. Okay, so now we'll talk about intestinal obstruction. There are two different types of mechanical obstruction. A person can have an actual mechanical obstruction, or the person may have a non-mechanical obstruction. And so with a mechanical obstruction, this is something, it could be a problem outside of the intestine, maybe scar tissue development, adhesions, or a hernia. It could be something that develops inside of the intestine, such as a tumor, a person having irritable bowel disease. Now, this is different from irritable bowel syndrome. Or the person may have an actual obstruction of the intestinal lumen. Okay, so that's a mechanical obstruction. Some type of mechanism is actually obstructing the colon. It could be a small bowel obstruction or a large bowel obstruction. But there's also a non-mechanical obstruction known as a paralytic ileus or a dynamic ileus. And so with a non-mechanical obstruction, this is when peristalsis fails to propel intestinal contents, although there is no mechanical obstruction. And so it's common to see non-mechanical obstructions develop after a person has had an abdominal surgery. Okay. With strangulated obstructions, which can be a type of mechanical obstruction, these can result from tumors, hernias, fecal impactions, strictures, intussusceptions, volvulus, fibrosis, a vascular disorder, and adhesions. And so here are two different types of mechanical obstructions that are shown in your book. You have a volvulus, where you actually see a twisting of the bowel on itself, and rotations of the loops of bowel. And so what we have to remember, when the person has a strangulated obstruction, which is what we see here, not only is the bowel obstruction, but the blood supply to that portion of the bowel is going to be compromised. And so if this is not corrected, if this obstruction is not corrected, then you have this portion of the bowel that is going to die because of a lack of blood supply. And so what are the clinical manifestations? Definitely, I would think the person is going to have some mid-abdominal pain or cramping with a mechanical obstruction. They're going to have vomiting. And so if you think about it, if the person has an obstruction and if this person eats, well, once it hits that small bowel or that colon, the food can't move. There's an obstruction. And so once it hits that obstruction, it's coming right back up. Okay, and so the person is going to vomit. They're going to lose fluids, electrolytes, and so the person is at risk of developing hypovolemia and hypokalemia just because of the vomit and the loss of fluids. Obstipation is an intractable constipation, and so this is when the person can't pass gas or stools. And so we tend to see this one with the non-mechanical obstruction as well. The person has the stomach is asleep, and that's typically how I explain it to my students. It's a paralytic ileus. The ileus is a part of the small intestine that's responsible. The person takes in that chyme bolus and it moves through the small intestine and it's broken down. Well, when that bolus or whatever reach the ileum, well, it can't go anywhere because the ileum is still asleep. It's paralyzed, and so anything that person eats is coming back up. And so the person may have diarrhea. They're going to have some abdominal distension, and so that's going to occur because water is going to be drawn into the bowel lumen, and so it's going to cause the abdomen to become distended. Borborygmy, this is when a person has those really loud gurgling bowel sounds, and it's produced by the movement of gas through the intestines. And also, the person is going to have an increase in that rumbling with a mechanical obstruction, actual mechanical obstruction, because you have food and you have gas trying to push past the obstruction. Now, the person with the non-mechanical obstruction, this person is going to have very decreased to absent bowel sounds. So that's kind of your difference that you're going to see here. Also, when we talk about the abdominal distension, the person is going to have ingested fluid and saliva and gastric juice and pancreatic enzymes. All these things are going to lead to the abdominal distension. Also, because of the distension of the bowel, it's going to interfere with peristaltic movement. Okay, so you've got the obstruction, the actual obstruction with the mechanical obstruction. Something's blocking it. But then, because of the interference with the bowel, this is going to interfere with peristaltic movement as well. So how are we going to fix this? We'll talk about that in the next upcoming slides. But again, with the non-mechanical obstruction, the person is going to have a constant diffuse discomfort. They're going to also have abdominal distension, but as I mentioned, they're going to have decreased to absent bowel sounds. They may also have vomiting and obstipation, that intractable constipation. And so some typical reasons that we see non-mechanical obstructions occur. Medications such as narcotics, anticholinergic drugs can slow gastric motility. Hypokalemia can cause a non-mechanical obstruction. Definitely spinal cord injuries can cause a person to develop a non-mechanical obstruction. And so again, definitely after surgeries, the person can develop a paralytic ileus. And so what are we going to do as far as our assessment? X-rays and CT scans can be done to confirm if there is an actual bowel obstruction. Labs can be done to determine if there's an infection present. Fluid and electrolyte imbalances may be determined at this time, especially potassium and chloride. They're going to be lost through vomiting. The person may have an increase in their white blood cell count. They may have mild leukocytosis due to the inflammation. If ABGs are drawn, it may show that the person has a metabolic alkalosis, and we're going to see this developing because the person is losing hydrochloric acid from the stomach when they're vomiting. Other diagnostic tests that can be done, a urine-specific gravity can be performed, and so this is going to show an increase in urine-specific gravity if the person is not eliminating appropriately. So, non-surgical management includes nothing by mouth. If there is an obstruction, well, we don't need this person to eat anything because they are not going to be able to digest it appropriately. A nasogastric tube or nasointestinal tube is going to be placed to assist in gastric decompression. As I said, gas builds up, you have fluid build up, gastric acids build up, and so they're going to place this to help decompress the stomach. With IV fluid replacement, as I said, due to the vomiting and maybe diarrhea, the person is losing fluids and they're at risk for hypovolemia, definitely a loss of electrolytes. So we're going to replace fluids and correct any electrolyte imbalances before the person has surgery. Mouth care is going to be important. The mouth becomes very dry, especially with the person being NPO, and if the person is vomiting fecal contents, well then of course we want this person to perform mouth care because we don't want them, to build up bacteria through the mouth as well. So we want to make sure that they're performing mouth care. Pain management, really with this person is going to be more comfort measures, changing the person's position. We don't want to give this person narcotics because they're going to slow gastric motility. Sandostatin is a medicine, that's SANDOSTATIN, is a medication that enhances gastric motility. So this medication can be used for the person that has the paralytic ileus because again it's going to help with gastric motility. Prophylactic antibiotics may be used because the person is at risk for developing peritonitis, and we'll talk more about that. With our surgical management of this patient, exploratory laparotomy is when they're exploring the problem. And so this is a small incision made into the abdominal cavity to determine where the actual obstruction is. But remember, before any type of surgical procedure can be performed, fluid and electrolyte problems have to be corrected first. During the procedure, again, with the exploratory lab, if the person has any type of adhesions, these adhesions can be lysed during the procedure. If there is a tumor, tumors can be removed during the exploratory lab. A colon resection can also be performed. After the procedure, in the postoperative period, again, the person is going to have an NG tube placed until peristalsis returns. And so the way we determine peristalsis has returned is by return of bowel sounds. But also, I've read before that something that's more diagnostic than bowel sounds is the person actually passing flatus. This is also another way to determine that peristalsis has returned. Okay, so the last thing that I will discuss today are polyps. And polyps are small growths in the intestinal tract that are covered with mucosa and are attached to surfaces within the intestine. There are different types of polyps. And so in your book, they show you two different types of polyps. You have your pedunculated polyps, and then you have your sessile polyps. And so your pedunculated polyps are those, they're on a stalk. Okay, so they're attached to a small stalk of skin. And then you have your sessile polyps. They tend to have a larger base, and they're flatter. And so when you compare the two, the pedunculated polyp is more likely to bleed. And so when you look at the different types in the book, the pedunculated polyp, as I said, is more likely to bleed because as stool pushes past that type of polyp, it's more likely to irritate it and cause it to bleed. And so with these type of polyps, they can be malignant, but they can become cancerous. With your sessile polyps, I've read in a book before, and it may not necessarily be in this book, but these type of polyps, they're overlooked often because they kind of blend in with the gastric mucosa. Now the pedunculated one is just hanging out there. It's visible and a person can easily see it, but sometimes the sessile polyps are missed when colonoscopies are performed because they're flat and they blend in with the gastric mucosa. And so sometimes because of that, when a person is having a colonoscopy and they're missed, they're not removed and they can become cancerous. So one thing that's being looked at in research are slowing the withdrawal times of colonoscopies. A colonoscopy is a really quick procedure, but because of those polyps that have that flat morphology that are blending in a little bit better, they're recommending slower withdrawal times to really look at that right colon and to determine if there are polyps that may be missed. And so again, this is an example of a pedunculated. And as you see, it's on a stalk, but the sessile is flatter. Okay, and as I said, these tend to be missed. Some complaints that the person may have, as I said, they may have some gross rectal bleeding. They may have some obstruction. Intussusception may occur when a person has polyps. And so what can be done for polyps is a polypectomy, which is when they go in and they remove that polyp. And so this may be done when a person is having a colonoscopy or sigmoidoscopy performed. And so again, they're going to remove them to assess for any malignancies. After the procedure, nursing care includes monitoring for abdominal distension, any pain, rectal bleeding, or fever, which may indicate that the person is developing an infection. We want to let the person know that a small amount of bleeding is normal after a polypectomy, but it should not continue for an extended period of time, for days after the procedure is performed.